Thank you, Chair. I think from what we've heard, it's fair to say that the spare capacity that ministers have talked about actually wasn't spare at all. It was to the expense of people like Mr. Martinez. One of the issues that you've talked about COVID clean or COVID light facilities has been about the whether the patient themselves is clean, but I want to ask about staff. Particularly around how often we're going to look to have staff tested that are working at COVID clean or COVID light sites. And we had thousands of staff shortages before this pandemic. I was wondering if we would need to see an increase in the number of staff if we were to have separate facilities, and what impact this would have on staff that are shielding.
Derek, do you want to come in first on that?
Yes. Look, you described some very real problems here. I think that in terms of staff testing, it's absolutely essential to regain public confidence that we are able to test our staff regularly. We feel that this probably, pragmatic sense, is about twice weekly in order to do that, bearing in mind that we know that the tests are not perfect. As far as workforce goes, I mean, this is a really critical issue. And of course, it's everybody who's concerned with delivering surgical care. So it's theatre nurses, it's ward nurses, it's porters, it's physiotherapists, etc. And in different parts of the country, we know that we were desperately short in each or every one of these areas at different times. So maintaining the existing workforce that we have, the people who have come back, trying to get them to understand that we are a long way from getting out of a crisis yet, are really important messages to get across. And then, of course, there is the issue of if we are going to try and function on more sites, then you have to split your teams, as it were. And that, of course, again, has a workforce implication. So the logistics of it are complex. That's one of the reasons why we're struggling to get going again, but it's absolutely vital.
Catherine.
Same issues. We can't build confidence in patients coming into hospitals if we can't be sure that we can protect everybody. Making sure that staff are not carrying the virus, because asymptomatic spread is a worry, and staff-on-staff infection is a worry. So we know PPE does work. When you've got full PPE, the chances are much reduced of being of picking up the problem. So we need to make sure that we have got hand sanitizer, face masks for patients, and if we start having visitors back into hospitals, that we need to make sure that staff in their areas where they're not face-to-face clinical, so the coffee rooms, the seminar rooms where we do our training, all of those areas are, we manage to social distance, everyone's washing their hands, we're wearing face masks, and all of those things are happening, because that is a real problem. So productivity of everything drops in this situation. Putting on PPE, taking off PPE, doing all of that just takes time, and it adds time to every single encounter. And it also adds problems to communication. We did a quick survey of our members and fellows, and 97% of them said it's more difficult to communicate wearing PPE. So even doing the simple things like having a conversation takes longer when you're wearing PPE. Wearing a face mask all day is really tiring. It dehydrates you. You just feel tired by the end of the day, and you get people with skin problems from wearing a mask. It's very uncomfortable, and all of that adds up to a productivity issue. So workforce is a real concern. We want to retain people. We want to make it possible for people to stay in the system. Obviously, young trainees are not traveling abroad so much this summer, so we will have, I think, a good number this August, but my worry will be when we get round to the next part of the year, if we get to February, we may lose a lot of staff. And the other thing is people towards the end of their career, people who are near retirement, will this be, I've just had enough, I can't be doing with this. This is not how I thought I was going to be spending my day, and I'm now going to retire earlier. So we've got a real worry at that end of very experienced people who may just feel they've had, you know, this has been great to deal with the crisis, but the aftermath is just a bit too much to take forward.
Thank you very much. One of the ways that wards are plugging the gaps is through agency staff. And I wondered whether you knew if there had been any communication around trying to keep agency staff working in either dirty areas or clean areas, COVID areas or non-COVID areas at all, because that is an issue of concern.
I mean, certainly emergency departments, we use agency staff, but certainly in my experience, it tends to be agency staff that we've used always and tend to be loyal to that department. I think talking about clean and dirty is a bit difficult, and we tend to try and avoid doing that. The reality is that everywhere is going to be at risk. Some places are going to be lower risk. And we will be very lucky to have anywhere that would be COVID zero. I think everybody needs to recognise that there are risks, and we need to make sure that all staff that we use are well trained, understand the risks involved, have had risk assessments so that they can feel confident to be at work. But I'm not aware of anywhere that has said we're not going to be using the staff that they've previously been using.